So today we're going to be discussing the abdominal physical exam. So before we get started, I want to point out that we have our patient lying on the exam table. I am on the patient's right side. I'll be standing up for this exam. I'm just sitting to introduce it. But wanting to be on the patient's right-hand side. And we'll want to have all of our tools with us within hand's reach. So the two tools that we'll need for this exam are the stethoscope and the centimeter measuring tool. So before we get started, we want to make sure that we have our fingernails trim and clean. So if we look at our hands with our palms facing towards us, we should not see any whites of our nails showing. This is really important for all physical exams to make sure that we keep the patient safe. So this exam will be pressing into their abdomen. We want to make sure we don't cause them discomfort or, of course, harm them. So it's important to do from the beginning. So once we have clean, trimmed nails, the next thing that we can do is go ahead and clean them. So either using hand sanitizer or using soap and water. So I'm going to use hand sanitizer today. I'm making sure to cover all surfaces, tops, bottoms. Covering for about 15 to 30 seconds until all of that sanitizer is dry. All right, so I'm going to go ahead and move my wheelie stool out of the way. All right. So to start us off, I'm going to go ahead and introduce the exam and introduce myself. So hello, my name is Dr. Grace. I'll be performing the abdominal exam today. This includes feeling, listening, and pressing on the abdomen. Is it okay if we get started?
Sure.
Okay, wonderful. So to get started, I'm going to have you go ahead and bend your knees for me, placing your feet flat on the table. And if I can have you bring your waistband down to your hip bones, and then bring your top all the way up to just the top of your ribs there, or the bottom of your ribs there. Okay, great. Okay. And for this exam, you may or may not need a drape, but it's important to offer it. And as far as draping at the medical center, we can have either a sheet, a twin size sheet, or we can use a gown, a cloth gown. With female patients, certainly, or patients wearing shorts or dresses, skirts, of course, using a drape is necessary and appropriate. So I'm going to go ahead and just demonstrate how we would do this. So, all right, Kelly, if I can just have you go ahead and tuck the drape into your waistband, and then just bring it all the way down to the hip bones there. Okay, and if I can have you straighten your legs just a little bit more, just extend it out very much. So perfect. So if the patient's knees are too upward or too bent, and it will interfere with your ability to get to the accurate place, it's appropriate for you as a clinician to just redirect them and reposition them a little bit so that you're able to get the information. Same thing if the patient perhaps didn't bring their pants down to their hip bones, and it was just right below their umbilicus, I would want to correct them and go ahead and ask them to adjust that before we get started with the exam. Proper draping and exposure of the abdomen allows us to make sure that we cover all the areas. Okay, so the first part of the exam is observation. So I'm simply looking at the abdomen, looking for any abnormalities. So I'm still standing on the patient's right-hand side, but I'm also going to come down more towards their feet so that I'm able to see if there's any asymmetry that would be better visible from this angle. So I'm looking for any obvious masses that could be seen, any skin changes that could show any bruising or jaundice that would be present. Also could see potentially caput medusae, which we'll talk about in lecture, distended veins around the umbilicus. So the abdomen appears flat and symmetrical, and there are no obvious nodules or irregularities present. And are you experiencing any abdominal pain today?
Not currently.
Okay, very good. So if the patient was experiencing pain, we would want to try and examine that that location of pain last. So we would start above that area and end with the area of pain. But because he doesn't have pain, we're going to go ahead and begin all of the exams in this right lower quadrant. So after we have observed, we're going to begin with listening. So I'm going to be using the diaphragm and the stethoscope. This may feel a little bit cold. So I'm going to be dividing the abdomen at the level of the umbilicus, top and bottom, and the umbilicus right and left. So we have right upper, right lower, left upper, and left lower. And we'll be listening for vowel sounds in each of those 4 quadrants. Listening for a maximum of 2 minutes before moving on to the next spot. Likely you're only going to need a matter of a few seconds to hear those vowel sounds. But you're taking into consideration the tone and the frequency of those vowel sounds, comparing them from one quadrant to the next, to the next, to the next. All right, once again, this may feel a little bit cold. Okay, and once I've heard the vowel sounds, gotten a sense of them, go ahead and move to the next quadrant. Okay, very good. So there are positive vowel sounds in all 4 quadrants. Now we're going to be listening to the vessels. So to listen to the vessels, we're going to start with the the abdominal aorta, which is located 2 inches above the umbilicus, midline. So auscultation for any bruits in the abdominal aorta. And then we'll move over to the renal arteries, which are about 2 inches up and 1 to 2 inches out from midline. So a smaller abdomen, we would be airing more on that side of the 1 inch from midline. And then for the iliac, we want to go 2 inches below, 1 to 2 inches out. So all 5 of these auscultations will be very, very close to the umbilicus, a matter of a few inches outside of that perimeter. Because if there is a bruit, that clacking that likely causes this is going to occur at the bifurcation, which occurs closest to midline. So we want to listen where it's most likely to be heard. Because we're listening in the abdomen, we don't have to have the patient hold their breath or change their breathing in any way like we do auscultating for carotid bruits. With this, we'll be listening with our bell. So the abdominal aorta, listening just simply 2 inches above midline. We should hear nothing except vowel sounds. Moving to renal, 2 inches above, 1 to 2 inches lateral. We're going to check bilaterally. The other finding with the renal arteries, other than atherosclerosis, that can lead to bruits is stenosis of the arteries, which also can be heard. And then the iliac, 2 inches below, 1 to 2 inches out. Okay, and once again, we want to hear nothing other than possibly some vowel sounds. If there was a bruit, we would hear turbulent blood flow with every beat of the heart over that area, over that bifurcation. So there are no bruits present in the abdominal aorta, renal or iliac arteries bilaterally. So after we have observed and auscultated, now we're going to move on to percussion. The patient doesn't know what percussion means, so I like to tell the patient that I'm going to be tapping on their abdomen, listening for any abnormal sounds. So I'm going to be starting in that right lower quadrant. The important thing to get an appropriate or adequate sound is to make sure that you get the tissue slack out. So I'm going to be percussing with my right hand using all of the movement is coming from my wrist. So I'm going to keep my elbow still and simply flick my wrist. And I want to strike kind of very deliberately. I'm trying to make a sound. And so I want to make sure that I have good movement here with my dominant hand, but also my non-dominant hand getting that tissue slack out, pressing through the surface of the skin and that top layer of adipose tissue so that I'm able to get the most amplified sound possible. So I'm going to be just tapping on your abdomen. Let me know if there's any pain. And we don't expect pain, but if there is pain with percussion, of course that is likely a sign of something pretty serious going on, because it's likely a peritoneal sign. All right, so I'm going to be pressing. I can press simply straight in if there isn't very much adipose tissue. If there is more tissue that I'm working with, I can press in and then drag towards me. And I'm just using the floppy wrist. Hope that can be heard. And I'm going to be going about 9 spots or so outside, and then 3 or 4 spots around the umbilicus. I can go all the way out and then come inner, or I can do kind of a star pattern going from the outside to the closer to the umbilicus, further outside, closer to the umbilicus. The important thing is that we cover all of the areas, including the epigastric area. So here I would actually go ahead and adjust. I'm going to just adjust your shirt just a little bit here, just so I can get that epigastric area and I know I won't miss it. So just a couple of taps per spot is all you need, simply to get a sense of if it's resonant or hyperresonant or tympanic. Should be tympanic. You can see that I'm changing my hand position in order to get to the different areas. Here I might be upward. If I'm coming over here, I might need to reposition so that I'm able to simply have one finger against the skin. So I'm going to demonstrate how it sounds different if I use tissue slack versus if I don't. So if I barely press onto the abdomen, that's as much as I can get. If I press in, and if I press in more and backswing more, much louder. So it's a combination of all those different steps, and it just takes practice to get the motor skills and the dexterity of it. So I'm going to just finish up where I left off, making sure I cover all areas. So I've done right lower, right upper, epigastric, left upper, left lower, as well as the suprapubic area. So the abdomen was tympanic upon percussion. And was it tender at all, any areas?
Yep.
Very good. As well as non-tender. All right, so for the next part, we are going to percuss the liver. So I'm going to go ahead and have my centimeter measuring tool already ready to go. I'm going to, because a normal liver shouldn't be more than 12 centimeters, I'm going to just bring it out to about 14, just give myself a little room just in case, and have it ready. That way, once I mark it with my other hand, I can simply reach over and grab it, and I don't have to try and extend it and have to start all over again. Okay. So for this part, I'm going to be tapping on over your ribs here, evaluating an estimate of your liver size. So I'm going to actually have you bring your shirt up for me a little bit further, just below your nipple for me on that side. Okay. So I'm going to start at, if this were a female patient, I would want to ask them to explain, just like I did with the male patient, that I'll be evaluating an estimated size of their liver, and so I'll be tapping over their ribs. So a female patient, we would want to ask her to go ahead and lift her bra and right breast tissue on that side so that we're able to percuss up, because very likely, as far as where the diaphragm is, it's just about nipple level. So we are going to get close. That superior border of the liver is very just below the nipple line for most people. And so we want to make sure that her hand is between our tapping hand and her breast tissue. This allows, and if we don't go ahead and have her prep and open up that space, or have our male patient open up that space, it's likely that we're not going to get to that superior border because we haven't gone far enough. So set yourself up for success, prep the patient in a way that will allow you to get the information that you need. So a healthy liver should not extend below the margin of the ribs, but we don't know that it's a healthy liver yet, so we want to give ourselves a little bit of room in the event that it is in fact enlarged. So we want to start at about the level of the umbilicus. So I'm going to be tapping just the same way, making sure I get that tissue slack and a nice backward swing so that I get a good sound. I'm going to hear a little bit of a different sound from moving over the tympanic abdomen to the ribs. There's a little bit of dullness that you hear, but it's very different than the dullness of the liver. The solid liver, very flat. So you might hear a slight change in pitch, but I will do my best to make a loud enough sound for you to hear that flat dullness of the liver. And once I find that, I'm going to mark it with one finger and then keep percussing up to find the top edge of that liver. And then when I mark it, then I'll grab my measuring tool. So you'll see me go through that. All right, so starting at the level of the umbilicus, and right now I'm at mid-clavicular line. Make sure to not move medial as you move upwards. Many students find themselves migrating towards midline. Tympanic. Still tympanic, but slightly more dull because we're over bone, but not dull like you will hear with the liver. There we go. All right, so we're going to start with percussion, starting at the level of the umbilicus. We'll get tympanic, slightly dull, but then we'll hear the shift to really flat dull, and then we'll keep percussing over the liver until we hear resonance. The superior border from the solid liver up to the lung is a much clearer difference in the sound than it is from hearing the shift from tympanic to dull down below. But it just takes practice and practice to make an adequate enough sound and then to hear that subtle change. So I want to go up to resonance and then come back down to the dull because I'm wanting to measure edge to edge. So I went from tympanic to dull, keep percussing dull, 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 and then I went up to resonance and then came back down to dull. Now I'm going to reach over and mark it using the centimeter side of my measuring tool, and he is about 8.5 centimeters mid-clavicular line, which is very normal and healthy. Okay, so I'm going to go ahead and have you, I'm going to do the same thing but in the midline. So if I can have you bring up the shirt just in the middle here. Okay, so if we think about anatomical landmarks, a healthy liver should not be below the ribs here, as well as the sternum here, the xiphoid. So we don't need to start all the way down at the umbilicus for this mid-sternal line. And we also better not think that we hear it in the epigastric area unless there's hepatomegaly. So once again, the liver lives much higher than most everybody thinks. So you're going to percuss up till finding the inferior border of the dullness, percussing up to hearing that resonance, and then back down to dull. This one we expect to be much smaller, of course, 4 to 8 centimeters. Okay, so I'm going to go ahead and start here. Tympanic. So tympanic and tympanic over bone, and then dull. So I'm going to mark dull here, and then use my finger to go up. It'll just be a couple centimeters likely. So I went up to resonant and then back down to dull. Looks like 4 centimeters, mid-sternal line. Okay. So percussion encompasses about 12 spots in the abdomen, and then percussion, estimated size of the liver, mid-clavicular line and mid-sternal line. And then our final percussion is going to be for the spleen. So now I'm going to change my positioning because I want to use this left hand across his body. So I'm going to move up here, and I'm going to reach across. I'm just going to be feeling on the other side of your ribs here. I'm going to be feeling for the last intercostal space, anterior axillary line. So the armpit crease, if you will, here. Anterior axillary, not mid-axillary where we're listening for that final lung sound on the side. It's more anterior. So you're wanting to make sure that you're not too far to the side here. All right, so I'm just going to be reaching across, making sure I'm palpating and I'm in the right spot, and I'm just in that intercostal space. So just breathe regular. I'm going to just tap. So it's tympanic. I'm going to have you take a breath in and hold, and then tap again. Good, and release. And I want to see that it is tympanic, and when he takes a breath in, it stays tympanic. If his spleen were enlarged, he would take that breath in, and the diaphragm would displace the spleen down into this space, and it would move from being tympanic to sounding dull. But Traub's space was tympanic upon percussion. Okay, and I'm going to practice good demonstration, and just because I just adjusted my glasses, I'm going to re-sanitize and clean. It's important if you touch something or move something accidentally, it's good to just go ahead and re-clean. Okay, so we have finished with percussion, and now we'll move on to the final part, which is going to be the palpation. So because there is no pain, we're going to go ahead and start with that right lower quadrant. And I'm going to be starting with a very light palpation, and then all over, and then I'll move into a deeper palpation. I'm going to be looking where I'm going, but also checking in with his face as I'm going, just to make sure that I'm not missing any grimacing or signs that there may be pain that the patient isn't volunteering. All right, so just let me know if there's any pain. Okay. Just going to be feeling. Patient doesn't know what palpation means, and that we want to make sure that we communicate with the patient in a way that they understand what's about to happen. So, tapping, listening versus auscultating, and feeling or pressing as opposed to palpating. So it'll be pressing on your abdomen. Let me know if there's any tender areas. I'm going to be using my right hand down below, backing up with my left. I'm using really the flat pads of my fingers and making little small circular motions to be able to get in to the tissue. This part is what's most important, having the knees bent so that it relaxes the musculature. I'm not moving too quickly, just trying to make sure I cover all the areas, including this epigastric area that's kind of off the beaten path. We want to make sure that we check up there. So again, I'm just going really light to start, but if this brought on a lot of pain, that might be all we need to know to send them in to get evaluated. All right, so I'm going to go a little bit deeper. So now I'm going to be pressing a little further. Going as far as I can, feeling through the muscles if there are any masses, basically tender areas for the patient. Okay, any tenderness with that? Okay, very good. So the abdomen was soft, there's no masses or organomegaly, and it was non-tender to light and deep palpation. So I'm going to go ahead and feel for a couple of different, there's a couple of different extra tests that we can do here. So McBurney's and Rousing's. McBurney's, we're going to be checking about 2/3 between the umbilicus and the ASIS. 2/3 towards the ASIS, closer to the ASIS. So I'm just going to be pressing in. Let me know if you feel any pain when I press it or when I let go. So I'll be pressing in using a small circle, going in slowly and then quickly releasing to allow that rebound response. All right, so McBurney's is on the right side over the appendix. Any pain here or here? Okay, very good. And Rousing, same thing, 2/3 towards the ASIS. Slow entry, quick release. Any pain here or here?
No.
Okay, very good. So if I did the exam slowly, it's not testing rebound tenderness. So it's really important to make sure that we advance slow and we quickly release to allow that. So negative McBurney's and negative Rousing signs. All right, so I'm going to go ahead and move on to palpation of the liver and the spleen. So I'm going to be using my hand underneath your ribs here. Okay. And I'm going to use the knife edge contact of my hand and use his breath. So I want to be about 1 centimeter inferior to that costal margin so that I have enough room to get underneath the ribs and advance a little bit. And I'm going to let the patient know that I'll be on his breath, pressing in and feeling. It shouldn't be painful. There might be a little bit of discomfort. All right, so I'll be pressing underneath here. With your breath, I'll just advance. Go ahead and take a nice deep breath in and all the way out. Okay, I'm just feeling that liver mark. And so checking for hepatomegaly. So there's no hepatomegaly noted. If they can take the full inhale and exhale, Murphy's is negative, or Murphy's sign is negative. After we've done the liver and gallbladder, we're going to want to reposition to feel for the spleen. So I'm going to take a couple of steps up towards the patient's head and turn my body a little bit so that I'm able to, I'm going to be lifting underneath your ribs on this side. I'm going to then use my top right hand, feeling underneath the ribs on this side. So you can palpate so that you've got your location. Once again, you don't want to be right against the ribs because you need to go underneath those ribs with his breath. So I want to make sure to give myself a little bit of room. I'm not as flat as I was with the liver contact, and I'm not as pointed as I was with the gallbladder. It's right in the middle. So I'm getting the tips of those fingers all the way underneath those ribs. The spleen, there's a lot more space over on the left-hand side than what we should feel on the right-hand side. We shouldn't feel anything if the spleen is healthy. Okay, so once again, just give ourselves a little bit of room. Let the patient know we'll just be advancing with the breath. So go ahead and take a nice deep breath in and all the way out. And see, I'm going with his breath, not advancing further, and I feel nothing. So there's no splenomegaly. Okay, so we've just got our couple of last special tests. So for this one, I'm going to need your assistance. If I can have you make this shape with your hands and place it across your belly button a little bit lower and press in and lift up just a little bit. I'm going to be placing my hands on either side of your abdomen and pressing. So this is the fluid wave test. I've got my hands placed on either side and I'll simply press one way and then press the other. I'm not slapping him, I'm just simply pressing. If there was ascites, I would feel the fluid impulse against my other hand across this barrier that he's making. If he were, as he did, made his wall too high to where it's not testing where the ascites would be, it's my job as a practitioner to adjust him and redirect him to do it correctly. Okay, so I'll just be placing my hands on either side and pressing. Okay, so there's negative fluid wave. All right, so this completes the front part of the exam. If you want to bring your top down, and you can go ahead and remove the drape from your waistband. For this final exam, we are going to be doing the CBA tenderness. So I'm wanting to go right where the ribs come and meet the spine here. So that costovertebral angle. It's important that we are using the palm of our hand at the costovertebral angle and not the fingertips, because we're able to create a much better impulse through our palm than we're able to create through the fingertips. And if I can have you turn your head towards me. And this just allows us to check in. Of course, if they jump off the table, we know it's positive, but if they grimace or show signs of pain without us outwardly hearing them, this helps us catch that. All right, so I'm just going to be placing my hand here, and I'm going to be striking my hand. Just let me know if there's any pain. Any pain with that? No. Okay, and I'll do the same thing on the other side. Keep looking my way. Any pain with that? No. Okay, so to demonstrate the amount of force, the kidney is very innervated. If it's inflamed, a little bit of vibration will cause a lot of pain. So we're simply creating enough force to create a little vibration through our hand into their back. We don't need to wind up and really strike them hard, but we also don't want to barely tap to where there's no vibration. So enough to create a little thud. And once again, making sure that we're off that costovertebral angle. We can also, if there is pyelonephritis, sometimes just feeling warmth and even visibly seeing erythema over that kidney can also be seen. All right, so no CBA tenderness bilaterally, and that completes the exam.